Yep.
Yeah, you can see it, right?
Yes.
Okay, good. Yeah, so this is a 40-year-old guy. Actually, this is a CT chest, but I'm presenting here for abdomen. Just that the important findings are in the abdomen. Sorry about that. So we see a few bilateral effusions, some lymph node, and the history is just shortness of breath, and this is some incidental finding that is important in the abdomen. Yeah, if you see anything important. Yeah, probably this image should tell the story. Any guess?
Well, it looks like they're missing their left kidney, and
Yeah.
a bunch of their bowel is mostly on the left side, but it's hard to tell from this one image.
Yeah, right. So the patient had, when I looked into the EPIC, then patient had a history of left-sided nephrectomy in childhood.
Then it looks like their fat on their left side is much less than the right, like in their subcutaneous fat.
Yeah, that's right. Yeah, so this patient had nephrectomy for Wilm's tumor, and the left side of the body, it was, like smaller compared to the right side. So this was hemi-hypertrophy in Beckwith-Wiedeman syndrome.
Wow, I haven't heard that in a long time.
Yeah, it looked pretty weird to me as well. And then I checked EPIC and I was, wow. Yes. Yeah, I think that's the one case. And
Swachchhanda, I have a question. Does
yes,
hemi-hypertrophy not happen by itself in Beckwith-Wiedeman where you have other like endocrine abnormalities, or is it like in this case, why is it Wilm's that was removed and hence there is like, is it compensatory or is it an independent thing? It's what I got confused.
I think Beckwith-Wiedeman syndrome has multiple features. One of them is Wilm's tumor. The other is hemi-hypertrophy. It is not directly connected with.
Okay. So there is an association of Wilm's with Beckwith-Wiedeman. Okay.
Yeah. Yes, Tom.
I got you. Thanks.
Yeah. Sorry about that. Yeah. Now, can you see it? So,
Yes.
yeah. So this is a 47-year-old female with history of difficulty urination. And so the MRI was ordered to rule out any urinary diverticulum. So probably, yeah, this is the T2-weighted sagittal. This is T1 post-contrast sagittal. This is T2 axial. And this is T1 pre-contrast. Yeah, so I think these two images should be the useful images first and second.
Looks like an homogeneously enhancing vaginal mass.
Low T2, so like a fibrous tumor of some sort.
Yeah, so this was, actually I thought initially it was pretty common because it's a vaginal leiomyoma. But when I read about it, it says it's pretty rare and about like 300 cases only reported till now. Yeah, and that was causing probably some urinary obstruction and leading to the symptoms for the patient.
Nice. Do you know if they resected it?
Yeah, they did that.
It seems very broad-based. Like that would be, they'd have to resect like part, I mean, it'd be hard to separate from the vaginal wall.
Yeah. Yeah.
Cool, thank you.
That's from me. Yeah, I'll stop.
Okay, Rupa?
Hey, Aarti, this is Gitanjali. I had 3 cases.
Okay, do you want to go now?
Yes.
Okay.
Aarti, I still haven't found my MRNs. I have lost them, so.
Okay.
But I'll let you.
Just let us know if you find them again.
Yes, thanks.
And then Gitanjali, we were talking about if you can double click to make the picture as big as possible.
Okay, yes. Yeah, I know it. Right now, you all must be seeing 4 images on a vertical screen. So I'll try my best. Okay. So My cases are very quick cases, young female. And if I don't give too much history, it gets easier. But the history on this patient was she's received a liver transplant and kidney transplant. She was 36 at the time of the scan, and she received a transplant 10 years ago for kidney disease and hepatic fibrosis, cystic kidney disease and hepatic fibrosis. So with that history, what would be your differentials for these lesions, for liver lesions? Show the arterial phase again. Any thoughts on?
I'm wondering about PTLD given the history. Initially,
Yes.
I thought like the arterial to the venous was reminding me of FNH, but they're so T2 bright and so
Yes, so our thoughts were exactly the same. I mean, if you don't have the history, then probably in a young female, that's what we think of, right? FNH versus adenomas. And this lesion was more ISO. So thinking of FNH, but then that history came in where we say that this patient has a liver transplant. So those are the differentials, but I think we favored benign lesions in this PTLD. We weren't really sure. It didn't look aggressive, not much of restriction. This one had a rim restriction, but this lesion didn't have, actually looks very bright here right now, but we actually that time thought they were benign lesions. And we did a quick search and I found one case report and then a case series talking about FNHs in a transplant liver. And their hypothesis was because transplant causes changes in vascular perfusion of the liver, and hence there is an increased incidence of FNH in transplant liver. So we called this as an FNH, and then we called her up for follow-up with EOVIST. And this was the EOVIST image, 20-minute delayed EOVIST image on her. And there was no EOVIST retention. And this was, yeah, so and this was after 3 months. So her lesions had remained stable, not changed. So if this was something aggressive like PTLD, it would have changed. And clinically also, they weren't thinking of anything aggressive. She just had mild elevation of LFTs and they biopsied the liver. She had some degree of rejection. So that was the explanation for her elevated LFTs. And this is another 6. So based on that exam, when EOVIS didn't show retention, then we called these as adenomas. And this is follow-up after 6 months, and this is the EOVIST, and these lesions are actually getting smaller in size. And when we discussed, the physician said that she was on OC pills, and then the OC pills were stopped, and I think hence that's the explanation for reduction in the size of the lesion. So these, we don't have path follow-up for these, but we have a temporal evidence that these lesions are getting smaller in size after stopping OC pills. So when we again looked for liver lesions in a transplant liver, the only things that show up are PTLD and infection is the other important differential. But I think in a young female, she has a healthy liver, a transplanted liver. So I think FNHs and adenomas are both possible. Just as a normal population. But there are case reports describing FNH in a transplant liver, but I didn't come across anything talking about adenomas in a transplant liver. So I think that probably more for discussion if anybody has any thoughts or if they've seen anything like this before.
Gitanjali, my question is, how long ago did she get the transplant?
10 years ago.
Okay, because that makes more sense that they wouldn't, if like these adenomas were already there, would they have even transplanted that liver in? You know what I mean? Like,
yes, possible. I mean, she probably
maybe they were very small, and then because she was, you know, a young
and she's a female, so you know, she still, the liver is under the influence of hormones, so maybe that causes growth of these lesions. And she was taking OC pills, and then after, when we called these lesions, her OC pills were stopped, and now we see regression of these liver lesions. So
and Swachchhanda is asking the underlying condition requiring the transplants. Do you know?
It was cystic disease, renal cystic disease with hepatic fibrosis.
Okay, cool.
Okay. Okay, again, this is I mean, we don't have to, it's not a difficult case to make a diagnosis, just an interesting finding. And again, the history on this was quite interesting. This patient has we see that there is an IVC filter, IVC rupture with a large retroperitoneal hematoma. That's again, extremely uncommon. This is the first extensive IVC, like, I don't know, a rupture or dissection that I've seen for the first time. And there's no history of trauma in this. So IVC injuries are anyways very uncommon. Most common cause is iatrogenic injury. They are seen with blunt abdominal trauma, but much less common compared to aortic injuries. And I think the interesting thing was when we're reading about it, that we realized why IVC injuries are less common is because veins have more compliant walls. They don't have layers as in the arterial system, like there's no intima, media, adventitia. So there is no, dissection of veins is really, really uncommon. But this patient had IVC filters. So then we read about complications of IVC filters, like if IVC filters increases the risk of dissection, they do. But again, when we read about the complications of IVC filter, nobody talks about IVC dissection or rupture. There are perforations, I mean, are known where the limbs of the IVC filters can extend beyond the wall of the vein and can infiltrate the surrounding structures. They can get into the vertebral bodies, adjacent organs, and cause damage, but didn't come across where they talked about frank IVC rupture from an IVC filter. But this patient had spontaneous onset of abdominal pain, no history of trauma, was brought to ED, scanned, realized that there is an IVC injury. He was taken to OR, but during surgery, he went into asystole and did not survive.
Gitanjali, can you expand the coronal view? And so this wasn't related to recent placement of the IVC filter, you're saying?
No, the IVC filter was placed a year ago in him.
Okay. Wow. So it's really
not even an acute injury. It was just spontaneous onset abdominal pain, no trauma, MVC history, nothing of that.
Struts look fractured.
Do they?
They look compressed to me, maybe because of the hematoma, like compressed together.
Like they're kinky.
Yeah, they're just displaced towards
Oh, gotcha.
side, but I think it's because of the hematoma. Yeah. So again, this was something that I had never seen before. And the other thing is the mortality with IVC injuries. If this was trauma, the mortality with IVC injuries is much higher than aortic injuries, again, because most of the patients don't make it to the hospital. They die at the scene because veins have, again, more compliant walls. They don't have a mechanism where they can constrict, unlike arteries, and stop bleeding. The only way to stop bleeding in this case is there's a big hematoma and that causes tamponade of the vessel. But in aorta, in addition to tamponade effect, it's the media and the muscularis that contracts and can decrease the amount of bleeding. So in fact, veins, larger venous injury causes more hemorrhage than aortic injuries. Okay.
When I was a fellow, we like that interventional division was like super aggressive about removing IVC filters. And like during my training, I was sort of like taught to say that in the report, if the IVC filter is no longer indicated, to like consider IR evaluation for removal. And I've seen something similar to it at an SAR workshop, where they make that recommendations because people forget that patients have they're walking around with these IVC filters that they don't need anymore. And it can lead to these severe complications later down the line.
Yeah, Nelly, that's a common problem because they'll place them temporarily for like a trauma patient and stuff. And then they'll unless they have a follow-up appointment with IR, they don't take them out. And those struts definitely can erode into the aorta, into the duodenum. I've never seen it rupture like this. This is crazy. But yeah, they do definitely need to be followed up.
Yeah, and again, venous injuries, as I said, are more common iatrogenically, like when they're trying to place it, and even retrieval is common, where they cause venous damage. But this one was spontaneous, a year after placement of filter. Okay. So last case is also a quick one, more of a companion case to what Victoria showed last time. A young female, she's 29 years old. incidentally detected renal lesion. This is the delayed. We have MR images too. So what would you all call this lesion? Just
What do
get
you
your
guys think?
measurements.
Looks like it's like herniating into the renal pelvis.
Could this be a multicystic nephroma?
That's what I was thinking. I've never seen them so separate though. Like it's usually like a
Yeah, like a one clustered lesion. Here it looks like it's just two different, like a bilobed lesion with one component extending into the renal sinus. But this on biopsy turned out to be MEST, mixed epithelial stromal tumor. And even so far, I don't know, I mean, just pardon my ignorance. I just read this when Victoria showed this case last time. Is we were trying to separate out whether we should call this as a cystic nephroma or a MEST. What we had traditionally read is MEST is in perimenopausal females. It's an unusual tumor. It has ovarian stroma. It's more hormonally dependent, whereas cystic nephroma is where it's seen in young kids and middle-aged females. But then I just read about this new WHO classification. It's not very new. It's in 2016 update that they have grouped cystic nephroma and MEST tumors under one category of epithelial stromal tumors of the kidney. And again, it's not important to differentiate that in imaging. That's what we discussed last time. There are cystic, complex cystic renal lesions that should come out anyways. And I think the main thing is they're pathologically also under one category. So it's really not important to differentiate this. The only other thing was multilocular cystic RCC, which again, WHO has given a new name to it, is multilocular cystic renal lesion of low malignant potential because it has less incidence of distant metastasis and it's really not that aggressive. Pathologically, these two are different, but cystic nephroma and MEST come under the same category of tumors. And so it's really not important. Both are cystic lesions that try to herniate into the renal pelvis. That's again a common imaging feature for both of them. And what they have separated is cystic nephroma in an adult versus a cystic nephroma in a pediatric population. The ped cystic nephroma, they're different because they have a different genetic mutation. So this was something that I learned new last time. So I thought I'll just share it because I had this case and I was surprised because I thought MEST would be more in older females. So we called it as a cystic nephroma because she was 29 years old, but on path, it turned out to be MEST. So I think it can happen because they're just similar tumors on path.
Gitanjali, I actually recently reviewed a paper also which talked about how they're trying to blend the two terminologies into one. So I spoke to the GU pathologist at length also, and she agreed that both were tumors along the same spectrum. And we shouldn't, like you said, they're very, very, even histologically, very, very similar.
Similar, yeah. So, I mean, that's what in 2016 WHO classification, these tumors have come in the same category. I don't know, what is it?
Yeah, like Steve is saying, path is, For once, actually, Steve, the path was a lumper, and the GU pathologist said, I don't know why this is still a question in 2019.
Yes.
WHO clarified this in 2016. So
yes, and then the papers go back to I have one paper pulled in front of me from American Journal of Surgical Path in 2007. They said that they should be called as REST tumors, renal epithelial and stromal tumors, again combining both cystic nephroma and MEST because they both have epithelial and stromal component in them. The only difference is MEST has more of stromal component. It has ovarian stroma. And cystic nephroma, on the other hand, has larger cysts and thin septae and low stromal component. That's the only difference. But otherwise, like maybe their immunohistochemical markers are the same. They are supposedly these Mullerian remnants arise from the Mullerian remnants within the kidney. So I think that REST was a really interesting term, renal epithelial and stromal tumors. So that's.
Gitanjali, that's awesome. I always was confused by MEST tumors. Like I always forget kind of like what they, because it's hard to bring it up and be definitive about it. But my question is, last time I talked to Ivan Pedrosa about my case that I presented here of the multilocular cystic RCC, he was telling me that they're doing more kind of watchful waiting of these like MCNs, multilocular cystic RCC, and presumably these MEST or REST tumors because they are so low grade that like you're going to lose that whole kidney if you take this out. So like, I almost wonder if that was my kidney, if I might be like, okay, like, would I rather lose the kidney or just stay with this tumor? That's this very low grade tumor.
Yeah, I think there is more and more evidence coming that we can just, I think, wait and watch on these cases and not really be aggressive and take them out, because the concern was whether these represent some form of cystic RCCs. But again, that the RCC that is more cystic and doesn't have any solid component, that goes in that WHO category of low malignant potential. So even that has very low risk of distant metastasis and being aggressive. So I think of all these like cystic lesions which don't have any solid component in them, I think it's okay to follow these up.
Awesome.
Okay, that was
Great
all. I'll
cases,
stop sharing.
discussion.
Victoria?
Can you hear me? Good cases. So any thoughts? Obviously, there are these bilateral adrenal masses. It's an older patient in her 80s.
This reminds me of the case Ben showed.
I was thinking the same thing.
He showed an oncocytic neoplasm of the adrenal glands. To me, lymphoma comes to mind too, but it doesn't look like as adreniform. And METs also.
This actually ended up being lymphoma, path proven, and this was beginning of October, however many years ago. And there's a point where I'm saying October. You can see that the disease is primarily confined to adrenals. There's some lung masses, and 1 month later, in the beginning of November, you can see that. If I showed you side by side, you would see that the lung masses are bigger, the adrenal masses are slightly bigger. Now you have additional, quite a bit of lymphadenopathy. So this, adrenal lymphoma is very rare. Most of them are B-cell lymphomas and actually carry fairly bad prognosis. Just quickly. Oh, okay. Well, this is just kind of like a wow case in terms of how badly non-contrast CT underestimate the disease. So you can see this is an MR, and the liver is studded with metastases. Pretty much everywhere you look, there's Mets. Same thing on the contrast, they're all hypervascular. This was carcinoid, and the patient had chest CT earlier the day, and you can see that you really can't see anything at all. So you would never suspect anything here. The only thing you can sort of pick up in the left hepatic lobe. So this is just I don't know. Every time I get a case like this, I get fairly scared how much we're missing or could potentially be missing a non-contrast CT.
Yeah, what do you recommend, like, for following up neuroendocrine tumor? Because I've seen the exact same thing. Even with the contrast-enhanced abdomen pelvis, it just totally underestimates the disease burden.
I've seen if you just get venous, portal venous, for neuroendocrine tumors, it may not be much better than non-contrast CT. If you have small Mets, we have a program, and they tend to follow them. They're a little more aggressive than they're probably necessary. They follow abdomen pelvis with EVIST. That's how they do it. I know that Sinai.
Yeah, that's the best.
I know that Sinai does abbreviated protocol, which I think they include DWI and just hepatobiliary phase. So once you establish the diagnosis, they just they inject off the scanner, and then about 20 minutes later, patients on the scanner, and then they get a couple of sequences and they're done. That's probably sufficient for just follow up. Okay, next case. This patient came in with diagnosis of potential cholangitis.
Victoria, can you speak a little louder or into your mic?
I'm literally, my face is in the mic.
Okay, thanks.
Okay. Anyway, so patient has clinical, history of cholangitis, and notice patient had Billroth procedure, partial gastrectomy. And as you come here, notice that there's the swirl. So there was a volvulus at the gastrojejunectomy. As a result, you can see that the roux loop is markedly distended, right? So that is called, does anybody know what it's called?
Afferent loop syndrome?
Afferent loop syndrome. So this patient actually had a tremendous complication of this. So check this out. Can you see it?
Yeah, it's blown out the end of the pancreatobiliary limb.
Right. So the roux loop is blown. You can see that the staple line is dehisced, and there's like air and fluid coming out. This is the cause of patient's cholangitis. You can see probably on coronal, you can see better. You can see little abscesses in the left hepatic lobe, and this is where the dehiscence is going right straight into the liver. And the patient also had concomitant necrotizing cholecystitis. You can see that the mucosa is what we call it, is compromised in multiple places, and it's probably because of poor drainage of the bile because of the afferent loop was so dilated. So this patient was sick, and this is it on the coronal, the swirl right there. You can see it kind of swirling a bit, and this is where the obstruction was. And this is basically the complication of the afferent loop.
That's a crazy case.
I know. All right, so this is a sort of kind of needs. Okay, so this is a 20-something-year-old, very young guy in his 20s, and he came in with hematuria, and his history is that he has a solitary left kidney. I mean, a solitary kidney. So this is what we see. You can see that the patient has one kidney on the right. On the left, there's a lot of inflammation, but there's really no formed kidney. And then this ureter, whatever ureter he has, is quite dilated, and it ends in this mass-like structure. And here it is on the dilated, oh, sorry.
Sorry, you says congenitally absent kidney, right? Not resected?
He said the history we got is hematuria with solitary kidney. So we assume it's and based on imaging, it looks congenital, because it doesn't look like it was here. It is on coronal. You can see it's probably some rudimentary parenchyma here. Very dilated ureter, and again terminates in this large lobulated, very low attenuation mass. So any thoughts?
So, ectopic. Is it an ectopic kidney with like a ureteral seal?
Yeah, Ben is bringing up Zinner syndrome.
Zinner syndrome, yeah.
Okay, so possibly, I don't know what syndrome he has. I'm more focused on the mass, but Nellie hit it right on the nail. So we thought it may have been like a ureter seal, but it's humongous. So I've never seen ureter seals that were this huge, but so we recommended cystoscopy, which they actually did. And on cystoscopy, that's what they saw. They saw just a large ureter seal, which is pretty cool. So it was like a mass-like appearance, but this was just ureter seal based on the path.
Victoria, quick question.
Yeah.
It's interesting that it was like so fluid filled, like, because if the kidney's not making urine, like what's filling up that whole ureter? And I think that's why Ben brought up Zinner syndrome, because that can be like the ejaculatory duct is affiliated with it, and it's making, maybe that's like a seminal vesicle cyst, or like, well, not really seminal vesicle, but like some kind of, like, why is it so filled with fluid if it's just a ureteral seal and there's no kidney working there?
I assume that there's a little bit of parenchyma here somewhere. It has to be like this part.
Got it.
There's no other ways. Alternatively, it's just huge reflux, right? But this is a semovesicle, so it's not this part is not this one is the ureter, so it's not the semovesicle. Semovesicle is more inferiorly, and this was ureter seal.
I had to look up Zinner syndrome because I didn't remember. So for the others who are like me, Zinner syndrome, looking up Google, as a condition, it's a triad. You get renal agenesis, ipsilateral seminal vesicle obstruction, and ipsilateral ejaculatory duct obstruction.
Thanks, Nelly. Okay, so this one I brought up. I think when the beginning, you got, the first case we were talking about potential, complications in patients with transplant. This is a patient who had in July-ish, somewhere in the summer, I don't remember exactly when, but about 7 months ago, had a combined lung liver transplant. And this was just done routine for abdominal pain, and we noticed this kind of soft tissue mass anterior to the aorta. This is the pre-transplant CT. Notice that there is no mass here, so this is something related to something new. We did MRI. You can see again the mass is here. We can probably see the restricted diffusion. Right, you can see restricted diffusion. There's really nothing else. There's no lymphadenopathy elsewhere. And so thoughts?
PTLD?
Yeah, so that's what we thought. Given that this is a new kind of mass in a post-transplant patient. This was biopsied, and they actually called it a B-cell lymphoma in the setting of post-transplant. So that it was a little more aggressive than your regular. You can see it here, kind of irregular, slightly heterogeneously enhancing, which isn't right. So anyway, so this is a post-transplant. This is lymphoma as a most aggressive form of PTLD. And it was just isolated to this one spot, so it was interesting. That's all I have.
Nice. Nelly, do you want to go?
Yeah. Let's see if I can get this to work. You want it small screen, right? I'm going to request that people chime in with teaching points because I don't have any slides prepared, and just picked up a few cool cases that I wanted to share. And I'm hoping that people will just add to the collective knowledge. So this is a preoperative imaging. What do people think?
I have a thought.
Do you have liver disease?
Did you say liver disease?
I'm asking, is there history?
Oh, no.
Can you show the coronal?
Yeah.
I'm wondering about an adrenal cortical carcinoma.
It's a renal mass.
It's a renal mass? Oh.
Yeah.
Oh,
Maybe it's an oncocytoma.
Yeah. This was resected and it came back to be oncocytoma.
It's
And
got
I'm like, I really wanted to see the segmental inversion, but I couldn't, this case didn't have it. Go ahead, Steve.
well, it's
teach
kind of
us.
got that sort of stellate-ish central
Mhm.
features that,
Yeah, and that homogeneous rind, like that T2 and the
very smoothly
periphery is good for oncocytoma. And usually a clear cell that's this big would be more necrotic, like even in the periphery, and then probably invade the IVC by now.
Yeah.
I'm sorry, what'd you say? The rind, the T2 dark what?
See how homogeneous that rind is? Like often oncocytomas will have a central scar, but then the rind there is very homogeneous.
Oh, okay.
That's good for an oncocytoma, and it's intermediate signal rather than really bright like a clear cell.
Mm-hmm.
And then if a clear cell was this big, it probably would have already grown into the IVC. So
Yeah.
oncocytomas can get really big like this without already metastasizing or invading.
Mm-hmm. And then the other thing that's been attributed to oncocytoma is the segmental inversion, where you have enhancing segments or part of the mass that wash out on delay. This patient didn't really have, like, so here, for example, and then so they call that segmental inversion. But since that radiology publication, they found that clear cell does this sometimes too. So it's not totally predictive of oncocytomas. Cool. Any other teaching thoughts from anyone?
That we don't have a foolproof way of diagnosing.
That's right.
oncocytomas.
Yes. Yeah. I mean, I, you know, could we propose biopsy? But this mass is so big. Like, yeah, I don't know.
Good luck getting a urologist to leave that in place.
Yeah, exactly. Exactly. This is a second case, patient with diffuse liver disease, status post-transplant, and I meant to show a different, okay, it's fine. What do you guys see? There's a lot, it's busy, but incidental finding.
Bunch of infiltrative soft tissue in the upper abdomen. Between
Yeah, patient has a hematoma.
And a thigh mass.
Yeah, thigh mass. Yeah. So don't forget the margins of the imaging. You know, it's a pitfall for us. Lung bases, MSK stuff, and the margins of the imaging. So
And Nelly, it looks kind of like spindle shaped, but I'm wondering if it could be like a leiomyosarcoma of the vein versus a nerve sheath tumor.
yeah, I think exactly. So I had a very similar DDX. I don't have path yet. And this is a third case. I don't know if I showed this already. I can't remember if I did. My apologies. If I haven't, this is a cute case. What do you guys think?
Is there like an exophytic pancreatic lobule?
Yeah, so this is a fishtail pancreas. It's a variant, and so it kind of splits up like a fishtail. So it can't, like, it can be mistaken for a lesion or a mass. But it's just a variant of like the pancreatic formation. So they call it a fishtail pancreas. It's a normal variant. So don't confuse that for a mass or something more suspicious or sinister. Any other teaching points from this case? Okay, those are my cases.
I have other cases where like there's like little lobules that come off the pancreas, like on the head and stuff like that. So I kind of, like if it looks feathery like that, I still kind of know that the pancreas can grow in other little lobules. Okay, Rupa, want to go?
Yeah, sure. Okay, can you see my screen?
Yeah.
Okay. Pregnant patient came in with right flank pain. In the interest of time, I will stop here. So that's the axial haste. This is the axial T2 fat sac.
So she has like hydronephrosis, but also like hyperemia of her adrenal.
Okay. Here's in and out. May be hard to see on this screen, but there's really no dropout or anything. And here's the pre-T1. I think this was the most useful sequence. So anything else we want to add, Arti, other than what we said?
Ben has written into the chat adrenal hemorrhage, like spontaneous hemorrhage of pregnancy.
Sure, possible, but that's why I showed you a pre-T1. to prove that it's not hemorrhage. So pregnancy being a hypercoagulable state, what else do we think can happen?
Ooh, venous thrombosis.
Right.
The adrenal vein.
Actually an adrenal infarction.
Ooh.
Yeah, so few teaching points. Let me stop share here and share my. I have to share screen again, sorry.
When you're finished, can you show the post again?
I don't have a post, Nelly, because she was pregnant.
Oh, pregnant. Got it. Sorry.
Yes. So uncommon condition, but again, we have to think of this when pregnant patients come in with flank pain. Normally, we're used to thinking they have renal pathology or hydro, stones, etc. And it's important to include as high as the adrenals definitely on any like pelvis scans we might do also, just to make sure we catch this condition. So the features they say that are typical are that the limbs will be elongated. There will be increased T2 signal, which our case had, and you can compare with contralateral. It can be bilateral many times. And this periadrenal edema is also described. There is no hemorrhage on pre-T1. These patients may need anticoagulation. So just a few more AJR. This is a really nice article which talks about just non-hemorrhagic adrenal infarcts. So they show cases which are bilateral, kind of similar to ours. Again, no hemorrhage on the pre-T1s. And then I found another interesting case where they say Crohn's disease is actually a predisposing factor also. This one had post-contrast, Nelly, so where they show absent enhancement in the adrenals. But similar periadrenal edema, interstitial edema within the limbs, that smooth elongation that we saw in this case. So this was just
I'm sorry. The infarct is arterial. Is that or venous?
Venous.
Venous.
More
Okay.
often venous.
Okay.
Let me share screen. So do you see it, Nelly?
Yeah.
I don't have a post contrast, but something to think about in pregnancy when we encounter flank pain. I've not seen many cases of this. Just something new I read about. So I do have another case. I will show it next time for a good reason.
Okay, I have a couple of cases. So this is my first case. This patient had a peritoneal dialysis catheter, and you can see they have this loculated collection in their anterior abdomen. And they were actually having drainage out of they're having vaginal discharge every time they had peritoneal dialysis. So we injected the peritoneal dialysis drain. I'll narrow my windows here. So we injected this drain with contrast, and you can see that contrast is layering in the collection, and it's also going into some other structures. What do you guys think?
Aarti, I won't answer.
This is not only a crazy case, but after I was looking it up on the internet, I found out that Rupa wrote a paper about this. So
lymphatic.
Fallopian tubes. Yeah.
yeah, exactly. So the contrast is in the, it's directly communicating into the bilateral fallopian tubes. And I'll show you Rupa's article, which was just kind of crazy. Let's see, where is it?
Actually, the nephrology people wrote this up. We gave them images. So it was crazy.
Nephrology or GYN? Oh, because it's
Nephrology wrote it up, but one of my residents actually cracked this case for me because it was his idea to inject through the PD catheter directly to prove.
So here's
that's awesome.
Another new one on me.
And basically what they talked about was that peritoneal dialysis catheters can, their case actually looked just like ours. So they injected the catheter and then you can see both fallopian tubes lighting up here. So they talked about that the peritoneal dialysis catheter can erode or fistulize into bowel, into the pleural cavity, and also towards the skin. But that one of the other reasons, their patient also had peritoneal dialysate discharging out of their vagina. And so they had thought that there was like a fistula with the vagina, but turns out it's just going through these open fallopian tubes, through the uterus into the vagina. So I thought that was kind of a crazy case. And happened to be the same one Rupa had too. I'm gonna pause my share for a second. Okay, this is kind of a eye test incidental finding. I'll scroll back and forth here. Let me know if you guys see anything. This is the image with the finding.
Can you window it a little bit?
Okay, do you want me to just tell you guys? This was actually
It's
missed
not a
on
spine
multiple-
thing, right?
What'd you say?
It's not a spinal thing.
No.
Okay.
Small
So
bowel.
anyway, it was missed on multiple exams, but here, this was a lobulated mass.
Wow.
And I will show you the MRI. Also blending in here with the fourth portion of the duodenum or the proximal jejunum loops. But the key for the MRI is the diffusion. And actually I'll go through. So you can see it's really lighting up.
Can you open the coronal
On the
CT?
CT, sure. So there it is. But really blends in with bowel. We were thinking maybe it's a GIST tumor because it was like touching some loops here, or something else. It's actually slowly growing over a couple of years. This was resected and it was a leiomyosarcoma of one of the branches of the gonadal vein.
Crazy.
So yeah, so anyway, that was just kind of an interesting eye test. Missed on multiple exams, but finally, luckily we got it before, you know, metastasized. I see people are typing into the chat, sorry.
If you
Oh,
make,
yeah, people are asking about a GIST or a D3/4 mass, but this was a leiomyosarcoma.
if you make a habit of sort of running the upper GI on every CT, I think you'll pick up stuff like this. And the colon. I don't bother with routinely with running the whole small bowel if it's not obstructed, but I kind of survey the mesentery in the small bowel, but I try to make a habit of running the whole upper GI and the whole colon.
That's a great suggestion. I run the colon, but I don't really run the upper GI.
Yeah, I usually do them in like 4 quadrants, and I think I still would have missed it because it was blending in so much. But really on MR, DWI, literally look at it and everything. Is I've seen us like, you know, afterwards, it's always in retrospect, like, oh, it's like lighting up like a light bulb on the diffusion, you know? So then this is just my last case. So there's findings in the liver. As well as the flank here. So this flank thing, I'll just tell you, you know, this basically looks like it has to come out, right? It looks like a very solid enhancing mass, maybe a sarcoma. And this turned out to be a hemangiopericytoma. So kind of low grade sarcomatous kind of lesion. But the other interesting thing is this patient had these lesions in their liver. I'll window it a little more. She was a youngish female. She has this, and I will tell you, it's not related to the hemangiopericytoma. 2 subcapsular lesions with some capsular retraction.
Does she still have an appendix?
Yes, let's just say she does.
And no ovarian tumor. So it almost looks like the scalloping, like the mucinous mets we see with scallop from
She still
outside.
has the appendix here. So this is just, actually Ben presented a case of this before. Oh, there might even be another lesion here. Multifocal subcapsular.
Hemangioendothelioma.
Yeah, exactly. So this was epithelioid hemangioendothelioma. I don't have an MR here to show like the targetoid appearance, but subcapsular, young female, multiple lesions, that's what you can think about. And we've talked about this in this conference before, how some of those patients are stable. Some people sometimes go to transplant. In this case, they resected each of these EHEs and the patient is disease-free. They also resected that flank hemangioparasitoma and they are now disease-free.
I wonder if there's a genetic link between those two pathologies.
Yeah, I was trying to find that and I couldn't. And then I kind of went down a rabbit hole of like, what are they? You know, like on a pathological level, and I got like super confused and decided to stop. And especially with the hemangioparasitoma, because I think those have been like reclassified. But I don't, does anyone else know about those? Francesca asked, did we do a biopsy? Yes. So we did a biopsy of the flank lesion and then they resected it. Although I would say for that one, they probably could have just resected it. And then for the liver to see if it was METs, because some hemangioparasitomas can be malignant, we biopsied the liver and then that came back EHE and they decided to do those segmental resections. And Nellie has another case, so go ahead.
Okay, I'm let me see. You know, I'm showing PET and PETs, like they're kind of hard. So, can you pause recording? Just I need to get the thing good to go. I think I'm good, right? You guys, okay.
Yes.
So I'm just going to carefully show this so I exclude anything that could be of anything worrisome. Okay, so the patient presented like this with jaundice. And there's biliary obstruction, obviously. And we said, you know, concern for obstruction, you know, like so like a lesion. Patient subsequently, what did we have? Just trying to, we had CT followed by another CT that you know show that they put a CPD stent eventually, and then there's maybe an intraductal pancreatic duct stone, but we couldn't still exclude like a lesion. So then they got an ERCP and it was negative. So we had a PET CT, and then this is what the PET shows. So they went back and did another ERCP, and it was negative. What do you guys think? There is an answer
Why
to
did they
this.
do an EUS and like biopsy that uncinate stuff?
They did.
Oh, and it was negative.
Came back negative, yeah. So this is the original presentation CT, or the, let me see. Yeah. So any other differential? So
Coronal again, the one you showed initially.
yeah.
Arwa is saying lymph node.
Let me see. I have this. Oh, this is the like way like back. Sorry, that's initial, which is normal. Hold on, is this the abnormal one? Yeah. This is the initial presentation when the patient had jaundice, obstructive jaundice. What else did you want? Sorry.
No, that's good. Arwa is asking about a lymph node. I still think it's very concerning. Like that PET had FDG validity there. So I don't know. I'm thinking there's
worry. I mean, if you're not getting cancer in a thing that looks like cancer in the pancreas, sometimes it's chronic or autoimmune pancreatitis.
Yeah, that's right. And so this came back as IgG4.
Yeah.
And when you look retrospectively, like, let me see if I can find a T2, you can see this stuff in the kidneys.
I'm looking at the kidneys, but yeah, that can be a clincher.
Right there, these like T2 dark stuff here, bilaterally.
That's awesome.
I've been in that conference before, and they have me pull up a case in GI conference and say, we thought it was pancreatic cancer, but we got negative biopsies. And I look at the pancreas, I'm like, yeah, it doesn't really look like adenocarcinoma. Then I noticed something in the kidneys, and I'm like, wait a minute, this is IgG4.
Yeah, exactly. And this is so yeah, very similar here. So don't forget about that.
That's a great case, and especially the kidney stuff. We should have picked up on it. But the PET wasn't hot in the kidneys, huh?
No.
Interesting.
I mean, I can show you the PET. I mean, they didn't call it hot, but I mean, I'm looking at it and maybe it is. I don't know. Maybe just a little bit. I don't know.
It'd
See if
have
I
to be
can.
raging in the kidneys for you to call it hot, right?
Here's the
It's a little inhomogeneous.
yeah. I mean, there's so much like FDG in the collecting system. I don't know if we can.
Yeah, I don't think it's a slam dunk.
Yeah.
Cool. Okay, it's 3 o'clock. See you guys
Bye,
later.
everyone.
Bye.
Oh, no, it's 1 o'clock.
I only live in East Coast time. I'm such an East Coast snob. Bye.